Bozo. That is a way to say hello or a formal type of greeting in Potawatomi. My name is Cassandra Solis, and I am the Associate Director of Health Affairs, Diversity, Equity, and Inclusion. And I support the Odehmenan Health Equity Center, or Odeh Center for short. On behalf of my team, I want to welcome you all to our last Odehmenan Health Equity Speaker Series program for the 2023-2024 school year. Developing a gender-based violence prevention program in Chicago, an example of community-based participatory research with Arab Americans. And just as a reminder that this program is being recorded. So for a bit of background, Odehmenan translates to this heart of ours in Potawatomi. The Potawatomi people are one of the original peoples of the Chicagoland area and one of the Three Fires Confederacy nations, who know this area as their ancestral home. I want to give full credit, appreciation, and gratitude to Donald Parrott, our friend, language expert and elder, who has been on the journey of creating this space since its inception and has provided all translations. Today, we are joined by Dr. Sarah Abboud from the UIC College of Nursing. Over the course of the Odeh Center's first year, we will be spotlighting the 7 health sciences schools and colleges in this series, and the College of Nursing is the 4th to be spotlighted. Stay tuned for the continuation of this programming in September 2024. Dr. Sarah Abboud's program of research is grounded in social justice and health equity frameworks and has 2 interrelated tracks. First, sexual health promotion and sexual violence prevention among Arab Americans, and second, sexual and mental health among sexual minority Arab immigrants. Alongside her research, her advocacy work centers on the invisibility of Arab, Middle Eastern, and North African, South, West Asian, and North African identities, and calls for the inclusion of a separate racial/ethnic identity category on the US Census reporting. She employs principles of community-based participatory research and qualitative methods, and aims to develop evidence-based research programs and interventions to improve health outcomes among first and second generation Arab immigrants, in the US. Dr. Abboud completed her BS and MS in nursing at the American University of Beirut School of Nursing, Lebanon, and her PhD and postdoctoral fellowship at the University of Pennsylvania School of Nursing. She's also completed a visiting faculty fellowship at Yale University School of Public Health Center for interdisciplinary research on AIDS. Without further ado, Dr. Abboud. Thank you.
Hi, everyone, and thank you for the introduction. But before I begin, before I get started with my talk, I want to bring everyone's attention also and awareness that April is Arab American Heritage Month. And so normally in April, it is time for celebration. It is time for sharing our culture, tradition, food, music with our colleagues at work, with our neighbors, community, and friends. However, this year, unfortunately, with the Palestinian people in Gaza facing a genocide and a man-made famine, there is really no room for celebration. And so in the past 6 months alone, more than 33,000 people, including children and healthcare providers, have been systematically killed, and more than 70,000 have been wounded with no access to healthcare, food, or clean water. And so being part of this amazing Health Equity Center today, I urge you all to speak up against social injustice and violations that are happening right now against human rights, and to also join calls for an immediate ceasefire. And so I would like now to go ahead and talk to you a little bit about my program of research that I have been working with the Arab community here in Chicago for the past almost 7 years now, putting together and developing a gender-based violence prevention program for the community. And so briefly, I will go over some information about why this topic is important, what is gender-based violence, about the understanding of Arabs and Arab American identities, about community-based participatory research and why this is important work to do, especially with this community. And I will do an overview of my project. And so gender-based violence also, it's an umbrella term that could also be referred to as intimate partner violence, as domestic violence. So there are so many different terms referred to under this umbrella term. Is one of the most prevalent and persistent issues facing women and girls globally. 35% of women experience some kind of physical and or sexual violence at some point in their lives. And in the US, 1 in 4 women experience intimate partner violence in their lifetime, with 70% of those experiencing intimate partner violence experience this before the age of 25. So when they are still adolescent, teenagers, or young adults. So this becomes really an important issue to address at a young age. And it is a significant threat to the health of our youth and young adults. And so gender-based violence is really the product of multiple interrelated factors at the different socio-ecological levels in our society. So there are factors at the individual, interpersonal, societal, and structural levels that all create different conditions where interpersonal violence can occur and shape gendered norms of violence that take place for individuals and put individuals in a vulnerable position for violence. So these are some examples, like experiencing abuse during childhood. These are factors at the individual level. Traditional gender roles when it comes to masculinity, femininity, what those mean. These are more societal level and how we address them in our communities. Tolerance for interpersonal violence, again, these are some norms that sometimes reinforce and tolerate certain aspects of violence. Alcohol and drug use have also been associated with increased rates of gender-based violence. And at the structural level, we see definitely poverty, unequal access to services, but also discrimination in all its form, whether it's racism, homophobia, transphobia, sexism, and anti-immigration policies, among others. So again, all of these work together to create these circumstances that put individuals at a vulnerable position. And we know from a lot of evidence conducted with individuals from all backgrounds that those who experience gender-based violence experience adverse physical, mental, sexual, and reproductive health outcomes that affects their health and social well-being as well. So specifically when it comes to immigration and gender-based violence, the immigration process itself exposes individuals to a lot of new environment, whether it's new sociocultural, educational, economic, political, or legal systems. So it puts individuals at this start of a stressful condition to really try to explore these new normals of their life in a new country. So for immigrants specifically, adding to what I previously described at those different socio-ecological levels, there are also structural, multi-level structural violence that heightens their vulnerability to gender-based violence. And so we see in our communities experiences of xenophobia, language difficulties, not being able to communicate, to express one's needs, limited knowledge of the legal protections and services that are available in the community, again, adapting to new social structures, but also some individuals who are moving without their families and social support, they feel socially isolated, and also disparities in economic and social resources, again, put immigrant individuals at a more heightened level of being vulnerable to gender-based violence. Immigrant women specifically are at higher risk for intimate partner violence than non-immigrant women. And this, we have evidence here in the US, but also globally. So Arabs and Arab Americans in the US really come from very diverse immigration experiences across the country. Typically, they are defined as coming from 22 different Arab countries, but this number changed based on the definition that you're using. But they've also came in so many different immigration waves and for so many different reasons. But more often, they've left their countries because of wars, displacement, and intergenerational traumas. So examples that we see among the Palestinian, Lebanese, Syrian, Yemeni, Iraqi immigrants who, especially in the last several decades, has been their case of leaving their countries. And so this community has a very high growth rate. So between the years 2000 and 2010, we saw approximately a 72% increase of growth rate. In the US specifically, the ethnic identity of Arabs adds to this vulnerability of who they are and how they are perceived within the society. So only until like end of March, and it's going to remain for a few years as well, Arabs and everyone from the Middle East or North African countries have been identified on the US census as white. And so this like misclassification or classification has really created this long-term invisibility of the community and also made their health needs unaddressed. So there are no large data sets that we can look at that could provide us with a clear understanding of the health disparities of this community. So they are, again, considered white, but at the same time, they're considered non-white when you look at the social and political perspective and perception, especially in the US. And so years of discrimination, racism, Islamophobia, and also these Orientalist approaches to understanding the relationship between the Western or global North and global South, and the stereotypes, especially around Arab men and women, also creates this hypervisibility of Arabs within the news, within the social context that we live in. And so these negative stereotypes, these discrimination and Orientalist narratives really reinforce a narrative of invisibility and hypervisibility and affects their daily lives. And so these are like some examples of decades of advocacy work done to look at this whiteness of the Arab identity in the US, how it really has impacted their health disparities. Again, especially their experiences post 9/11 and the discrimination that they faced. So on one hand, their health disparities are more comparable to other racial and ethnic minorities in terms of what their lived experience is about. However, they're again counted as white without the white privilege. Again, these are some other examples that pushed and has been pushing from researchers, community organizers, advocacy workers to really put a separate racial and ethnic category to identify the community to be able more to address their needs. So these are all examples from research studies, but also work that has been published in different types of medias, really pushing that people who are from Arab and Middle Eastern backgrounds do not really identify as white because no one sees us as white. So again, white without the white privilege. Are Arabs and Iranians white? Census says yes, however, the diaspora says no. So up until 2020, this has been the white definition of the white category on the US Census. So it includes one or more nationalities or ethnic group originating from Europe, the Middle East, or North Africa. And as you see, they provide examples from some of these countries. And these include Lebanese, Egyptian, Iranians, or Chaldeans. However, some great news finally, on March 28, 2024, so a few weeks ago only, the Office of Management and Budget finally updated and revised their minimum reporting categories based on race and ethnicity. And so now there will be separate check boxes for Hispanic or Latino and Middle East and North African for the US Census that's going to be collected in 2030. And all federal agencies have until 2025 to provide like a detailed plan on how they're going to be implementing these new changes. So it's going to take time to be implemented, but at least on the federal level, this is happening. And so here is how it's going to look like for the US Census 2030. And as you can see, there's going to be a separate checkbox for individuals who are from these countries. And so why this becomes an important approach, why community-based research becomes an important approach to use with this population. So in addition to what I've described around these complexities of understanding the Arab ethnic identity, but also the intersection of immigration with health, politics, discrimination, and years of lack of trust and fear from all different systems in the US, whether these are like the political systems, educational, healthcare systems, because of these stereotypes and discrimination that the community has been facing. And more recently, since October, and the lack of census data and national data set, it becomes really important to work with the community to address their health needs and conduct community-based research with the community. And so I use community-based participatory research principles in my work. And this is mostly based on these 9 large principles. I'm not going to spend a lot of time on them, but mostly these are principles that recognize our community as a unit of identity that we work with. We work on building the strength of the community and the resources within it. We really encourage co-learning capacity building where everyone has expertise in the work we are doing, whether these are community members or researchers and academics. We really make sure to integrate and achieve balance between knowledge generation and intervention for mutual benefit. And we work on also disseminating and making sure that the work that we do is back into the community. Is sustained programming is also part of our planning. And so this takes a lot of intentional work in terms of being reflexive on our powers, on our identities, on the power imbalance that we create as researchers coming into a community, even if we are part of the community. So making sure to understand those outsider, insider perspectives, how we as part of the community are still seen sometimes as outsider to the community, and making sure that we address these differences and privileges early on to ensure a collaborative and equitable partnership. So why I've done this work, moving to Chicago, it was really a new start for me, and wanting to make sure that I do the work in a very ethical and collaborative perspective. So I connected with other researchers here on campus who have connections with the Arab community. I made sure that I had this trusted connection, made sure to be present, to be responsive to the community needs, to take initiative, and to work on several years to build this trust in order to maintain the sustainability with the community. And so connecting specifically with Arab American Family Services, which is a community-based organization in the southwest suburbs of Chicago, really helped that we bring together our expertise and their experience working with the community for more than 20 years. I was new to the community and they were not. They knew the community needs. So one of the first things we did based on their recommendations were we conducted a community health assessment. We did surveys and focus groups with the community and identified some of their major concerns. And so one of them were addressing domestic violence and intimate partner violence, in addition to other issues like cancer, diabetes, discrimination within the community. And so bringing my work on sexual health, had to revise a little bit the way I look at sexual health, and also realizing that the community organization already had a domestic violence program that has been built for many years, but geared towards survivors. We really wanted to work on prevention work and do this primary work in this topic. And so we developed community advisory boards and wrote together collaborative grants to help us support the work that we did. And so Chicago specifically is among the top 5 metropolitan areas where Arabs live. And similar to Arabs around the country, they've also faced a lot of discrimination. And so it has affected their health in so many different ways, exacerbated their health disparities, and worsened also their vulnerability to violence, trauma, and stress. And so we also know from evidence with individuals who have survived wars or government or state violence that collective and community level trauma contribute to the community's vulnerability to interpersonal violence. So the trauma that is experienced at also the community level also builds down into the interpersonal level. And so previous research within the Arab community have also showed that there's a lot of obstacles in reporting and also in addressing gender-based violence within the community because of fear of reinforcing some of those stereotypes that Arab men are violent, Arab women are submissive. So reporting some of their experiences with intimate partner violence made them feel that they're reinforcing these stereotypes and push them to be more socially isolated. So the program that we worked on and started many years ago was really to using community-based participatory research approach guided by the socio-ecological and structural violence framework, and using the adapted model, which is a model used to adapt interventions to different contexts. We really wanted first to identify some of those unique characteristics that define and prevent gender-based violence within the Arab community in Chicago, and what we can identify as targets for prevention. We also wanted to evaluate two evidence-based programs that already exist and to see how they could be applicable to the community. And our third aim that is currently ongoing is the adaptation and pilot testing of the intervention. And so for the first two aims, we really used mixed methods design with multiple sources of data collection. It was heavily qualitative, descriptive in terms of doing a lot of one-on-one interviews with multiple stakeholders, specifically young adults between the ages of 18 to 25, but also other key informants. And we also conducted focus groups with young adults between the ages of 18 to 25 to evaluate those two evidence-based programs. So the one-on-one interviews was more to explore the characteristics of gender-based violence and understand factors that contribute to it. And the use of focus groups was more to evaluate the programs and their relevance to the community. All participants also completed surveys around their experience, exposure, attitudes around gender-based violence. We also developed a community advisory board that has been working with us for many years. However, as many of you who work in this area know, community advisory board changed over time. So people who started several years ago are very different than the people we have now. But we always have a community advisory board to report to at one point. These are some examples of some of our community recruitment. So again, understanding that having our community needs being very unique. So our community recruitment was very specific in terms of reaching out to different community organizations. So in addition to the Arab American Family Services that I work with specifically, we reached out to, for example, Arab American Action Network, the UIC Arab American Cultural Center, Moraine Valley Community College, which has a large Arab student body, a lot of festivals, events, grocery shops, restaurants, and of course, social media and personal networks. These are some of the community events that we either attended. So the community organization holds an annual domestic violence and cancer awareness walk. So that's the purple flyer. So we would attend, recruit from there, but we also put together community events. So knowing that this is how we also wanted to report back to the community, to have the community know the work that we are doing. We put together, for example, in April, an event around celebrating Arab women. So it was really lots of performances, arts, games, photos, and prizes. So we shared some of our preliminary findings with the community, and we were also able to recruit more for our study. So I'm going to report on the findings from the young adult samples, because these are the main findings that were really of interest to inform our program. So we had a total of 44 participants. We conducted 22 one-on-one interviews and 4 focus groups. And we held monthly community advisory board meetings and regular meetings with our community organization. So the survey findings, so very briefly, our mean age was 21. The majority of the participants, so 70%, were cisgender women, but we had a good diversity in terms of gender identity otherwise. Same thing for sexual orientation. We had 77% who identified as straight or heterosexual, and the remaining identified as bisexual, gay, pansexual, or queer. And 88% were single at the time of the study. So also just to be transparent, we intentionally recruited also individuals who identified as from the LGBTQ community, because we really wanted to have their voices well represented as well. As for from the survey, some of the standardized questionnaires that ask about experiences of sexual, physical, and psychological violence, victimization, but also perpetration, these numbers were really very high. So as you can see, physical and sexual violence was experienced by 47% of the participants. And this was a number of behaviors that were listed. And if someone reported at least one of these behaviors, that was counted as an experience. Psychological violence was experienced by 76%. As far as perpetration, similarly, 27% reported perpetrating physical and sexual violence, and 62% psychological violence. Themes from the one-on-one interviews, we had like 2 big themes. One was related to experiences and types of violence. So almost from the one-on-one interviews, 12 out of the 22 participants reported experiencing some form of violence. And this was experiencing it themselves. And others also reported being exposed within their own family environment to some type of violence. And that was most of the time violence between parents. And so when they were asked about what the gender-based violence looked like within their community, they talked about sexual violence, and that included being forced into having all types of sexual activities. They talked also about marital rape and about lack of consent in general, among other things. Physical violence also included experiences of being hit, pushed, shoved, also being threatened. Psychological violence, they talked about it as being one of the most common form of violence that they thought was present in their community. However, it was not talked about or seen as real violence because you cannot see it. You cannot identify it easily. And a lot of people do not know the red flags around psychological violence. So including being threatened to be violated in any way possible is also a form of psychological violence. As for factors contributing to gender-based violence, we analyzed the data based on the socio-ecological model. And so we had information based on like some factors that are related to individual level, relationship, community, and societal level. And I'll briefly go over some of these factors. So at the individual level, for example, they talked about history of exposure to interpersonal violence. So again, being a child or at any age and being exposed to violence puts a person at a higher risk of experiencing it again. Age difference between couples, and they talked about this being also prevalent within the community. So a large age difference between the spouses, certain personality traits like personality traits that reflect jealousy, unhealthy jealousy, of course, and all of other personality traits that can contribute to aggression. Certain financial struggles that puts individuals under a lot of stress, and also lack of education on gender-based violence. And so they talked about how a lot of, specifically women in the community, do not know what constitutes an intimate partner violence, what certain behaviors are not acceptable within a relationship. So this is an example from one participant who said, I think violence happens in cycles. If you experienced violence growing up, you're more likely to inflict violence upon the relationship you had, whether that's your children or your partner. Another participant said, I remember when we left Palestine and we came here, my father struggled, and I never realized this until I started to struggle at work. Living bill to bill, check to check, I never realized how that affects your mental capacity. Again, that's not an excuse, but it is a reason. Poverty is a form of violence. And when I said that hurt people, and when that form of violence is projected onto you, then you become a violent person. At the community level, they talked about lack of support system, especially for immigrant individuals who either move, so first generation immigrants coming to the US, and lacking the support of their families, of other friends, or resources within their community to really understand how to address any type of violence that they experience. But also, again, going back to this trauma-exposed community and how that puts them at a vulnerable situation. So this participant said, I came from a war zone. He was referring to his father, he was imprisoned at a time where most Palestinian men were imprisoned. He was tortured, and these things that he doesn't know that I know about him. So again, this participant were talking about how his father experiencing violence trickled down to his father being violent toward his mother and him experiencing those as he grew up here in Chicago. As for societal level factors, they talked a lot about the stigma related to divorce within the community. So with this stigma, it forces a lot of individuals to stay in unhealthy relationships and even violent relationships because they do not want to separate the family. They don't want to ruin the reputation of their families. They talked about certain religious norms that also push women to be more accepting of the status that they're in, especially if they're in a violent relationship. They talked about also of toxic masculinity that exists in all of our societies, and specifically about xenophobia and Arab racism. So again, this is an example from a participant talking about Arab racism. If someone is being degraded at work for being Arab, they come home and it's the only space where they can have power, so they will take advantage of it. That would lead them to being the abuser. Xenophobia from external systems, also part of it is the climate of specifically undocumented refugees. This sense of constant instability from external forces can filter into intrapersonal relationships that exist. So this is a very brief snapshot of like the findings. So I didn't go in all of the details of the one-on-one interview findings. As for the focus groups, so again, we presented with for the 4 focus groups, the 2 programs that we were interested in. One was called Safe Dates, which is a program here developed and implemented in the United States on preventing dating violence, especially among youth and young adults. And the second program is called Communities Care, which is a program that is developed by the United Nations in Sudan and Somalia. And so, and never been implemented in the US. And so one, Safe Date is a very interpersonal level program. Community Cares is a very community level program. So from the focus groups and the feedback we got from the participants, the young adults really wanted a young adult-led and focused program that teaches skills about healthy relationships, communication, but also violence prevention at large, but also a program that mobilized the whole community together to center its strength and change some norms that are related to gender-based violence. And so, again, from these main findings and formative research, we decided to adapt Communities Care, which has a component of an individual and interpersonal kind of skills building, but also works at the community level to change norms. excuse me. So this leads me to talk now about our third aim, which was the adaptation and pilot testing of the intervention. And so with the current work that we are doing, we adapted the toolkit or the curriculum of the program to make sure that it is eventually owned by the community-based organization. And we recruited facilitators to train into that program. And then the second aim of our ongoing program is to establish the feasibility of it, which means to understand really how much we're able to recruit, enroll, and retain participants, and how much do they accept it? Do they find it to be engaging program? Does it meet their needs? Do they want to change anything in it? And to also identify any barriers and facilitators of implementation. And so briefly, as I mentioned, Community Care, which is the program, it really draws on empirical evidence of effectiveness of social norms, interventions, and behavior change. So in order to change behavior, we need to also change the social norms that reinforce these behaviors. And so the aim of this program is to catalyze community-led actions to reduce tolerance of violence and to implement comprehensive prevention measures through transforming harmful beliefs and norms that foster violence within the community. And so it follows a framework that is called Pathway to Change. It goes through 5 different steps. Briefly, the first step is like to reflect on our community values, to explore what are the beliefs that contribute to violence, but also explore what are some of the norms that could be alternative to violence. To commit to taking action to prevent violence and to communicate these positive norms and changes with the community. And hopefully, step 5 is like a long-term building an environment that supports members of the community to sustain that change. And so currently we worked with 8 community advisory board members who were young adults and 2 community-based organizations. So Arab American Family Services, which has been long-standing partnership, and another new organization called Heart, Women and Girls, and our research team. Over the past year and a half, we worked through the program, which is 2 parts. One is building knowledge and awareness, and the second one is catalyzing change. And so for each of these parts, there's a curriculum that we worked on adapting with those stakeholders. And so this is briefly like the program itself that will be implemented. It has 4 phases, and it is over 15 weeks. Phase 1, and each of these phases build on one another. Phase 1 has 2 weeks, and it really works on building trust within the members of the cohort, as well as trust between the facilitators and the members. So they're getting to know each other, and they're envisioning a community or a world where we live free of violence. In phase 2, we're exploring values regarding dignity, fairness, justice, equality, and non-discrimination. So really these 2 phases build this groundwork to prepare individuals to address and talk about these stigmatized, sensitive, taboo topics that are very hard to address like immediately. Phase 3 digs deeper into creating reflections and understanding about violence, about norms that are related to violence, thinking also of power and how that connects to violence. And then phase 4 is more moving from dialogue to action, where the cohort will work together on making an action plan of how they want what they decided to change be implemented within their community and how they are going to commit to it. So these are some of examples of the work we did around the adaptation work. So we did 3 full days of adaptation with the Community Advisory Board. So we met from 9 to 5, going over every section of the curriculum. We got feedback from the Community Advisory Board. We did the same with the 2 community organizations. So also 3 days of, not full days with the community organization, it was shorter day, half days of meeting and getting also their feedback on what we did with the community advisory boards. And so these are some examples of like some of the evaluation of activities. Really, the research team, the community organizations, and the community advisory board, like they love the program. So we did not change any of the main topics because they're all important to see eventually some change in norms. But they definitely provided a lot of feedback on the activities that are going to be implemented to work with the curriculum. So ensuring when and how to separate the groups by gender or by age, how to introduce topics around LGBT issues, how the case studies reflect the community, like providing real examples from the community when we're talking about some case studies that they're going to work on and discuss. Understanding also the importance of religion, how it is not a tool to think about this to reinforce some of the norms related to gender-based violence, but how to use it as a positive tool to push for healthy relationships. And so what we are doing right now, we are also finalizing the pre and post-test instrument that will also assess change in norms and attitudes around gender-based violence. So the Community Advisory Board provided us with their feedback, and now we're getting feedback from the facilitators and the community organization. And we recruited 6 trainers or facilitators that are now being trained. So we've been meeting on Fridays all day to train over 6 days on how to implement the program. So their training is 2 full days of knowledge and awareness building around gender-based violence, self-reflection and awareness. But then 4 of the 6 days are all about skills and capacity building around leading large group discussions around stigmatized and sensitive topics. So we've been having a lot of like fun and activities on Fridays, like working with these 6 amazing individuals who have had previous experience working around gender-based violence. So it is not something new for them, but it's been very helpful that they've had that experience. And they're between the ages of 18 to 35. Actually, they're 18 to 31. And so again, younger individuals who are gonna commit to working with the community. And so in 3 weeks, we will finalize the training. And then we will be recruiting 24 participants from the community. And they will be divided into 2 cohorts or groups with 12 participants in each group. And there will also be mixed gender and mixed age groups. And as I said, yes, the activities are going to be sometimes hard to address with this mix of identities, but we have worked on identifying which activities could be separated and then brought back again together to discuss in smaller and then larger capacities. And then we're also collecting data around feasibility, acceptability of the whole program. So we will conduct focus groups with the 24 participants to get their feedback on the program itself. And so working with like community-based approaches, especially with topics that are hard to address within the community, offers on its own a lot of challenges. But with the work that we've been doing over several years, we have anticipated a lot of those challenges and put forth also how can we address them ahead of time. So obviously recruiting and retaining 24 participants, but also 6 facilitators over 15 weeks is something that we will be assessing in this pilot testing. It is a long program, and we understand that. But again, the feedback we got from the formative research was to keep it as 15 weeks. And again, because this program works on changing norms, it is not something that could be done in a few weeks. It requires a lot of discussions and dialogues around these important topics to be able to see any kind of change. Again, discussing of taboo topics is going to be a challenge. But as you saw, like the first 2 phases of the program really built on connecting together building that trust within the participants to hopefully facilitate this transition to talking about these topics. Language barrier might be at this point an issue. We are not able at this point to translate the program into Arabic, so we're going to be recruiting individuals who are fluent in English, even if they have, so our facilitators, most of them are also bilingual. So mostly fluent English participants will be recruited. We're going to also think of how to sustain this program with funding, with the community organization definitely is committed to working on gender-based violence prevention, but we need to think more of how do we also fund and support this kind of work. And of course, the constant worries and concerns about wars back home is something that all of the participants are constantly talking about, and the facilitators. So this is something that we need to acknowledge when working together with the Arab community. And so I want to thank every person who made this work possible, starting from the participants and sharing their experiences, to the different community advisory boards who came in and out and are still with us, to the funding we received from the College of Nursing, the Internal Research Support Program, the Institute for Research on Race and Public Policy, the Center for Health Equity Research, and the Rita and Alex Hillman Foundation. And also the two community organizations and our amazing research team, who has also been working really hard on doing all of this. Previous research assistant and current research coordinator are all from the community. So they are really invested also in working on this topic. Thank you.
Thank you so much. So we want to open it up for questions. Folks who are on Zoom, feel free to drop them in the chat or come off mute. And folks in the room, okay, you need the mic, so I'll walk the mic over to you.
Enjoyed really being here, Dr. Abboud. Thank you so much. So I'm Paige. A question I have is just trying to get a sense of how long it takes. When would you say from the start of you entering the community to start to build trust to this point? How long did that take?
It takes a while. So when I moved to Chicago in 2016 for the faculty position, so that's end of the year, obviously, it took almost a year to get to know who are the people that I needed to even start talking to, connecting with, meeting with the organizations, with some of the faculty on campus, and doing all of these networking. And so after that, when I got connected with Arab American Family Services, specifically naming Atidal Shalabi and Nariman Taha, who are the co-founders of this organization and working with the community for many, many years, we developed a sense of commitment to the work that we're doing together. And so obviously they've been also burned in the past by researchers from the UIC. And so I also needed to show that I'm committed, that I'm present, that I'm here for the long work. And I want to say it took around 3 years to identify the community needs, to identify a program that we wanted to work with, to do all the formative work. So some of it was pre-COVID, all the formative work we had to pause during COVID because also the community priorities shifted and the organization's priorities shifted around addressing the needs of the community. And now again, with the war, again, some of these priorities have been shifting. And so it's, as a community-based researcher, it's hard to follow a very strict timeline when it comes to research. And our research agenda or timeline might not at all work with the community. And I think we just need to be very aware of that and willing to accept that this is part of the nature of this work.
Can I just do 2 quick? So who would you say, you came to Chicago, and can you remember, was it through faculty, where you made that first contact to get you associated with AFS?
So Nadine Naber, who is a faculty here at UIC, she's a professor. on the East Campus. So she was my first point of contact. I knew of her before coming to UIC. I knew that she was from the community and well connected with the community. And she made that connection with the Arab American Family Services. And then the existence of the Arab American Cultural Center at UIC is a major asset to the community in Chicago.
Thanks. That's good to know because I'm like fledgling and trying to do CBPR. So just always trying to see examples really helpful. I think Nadine's listening today too. I'm sure if I saw her name. Yeah. Yeah.
Thank you, Nadine.
And then, so about IRB, so it can be really complex, right? To get IRB approval for CBPR, can just a little overview about.
So it takes time to get IRB in general and specifically here at UIC. A lot of it is because there's a lot of uncertainties sometimes with now with the facilitators program and training, and then with the pilot testing. There's a lot of moving pieces that's constantly happening, with changes in the curriculum, with the trainers, we get feedback with the training of the facilitators, we're getting feedback about some of the activities that could be changed. So going back constantly to IRB to get approval again about the training. And again, it takes 2 to 3 weeks every time to get a minimal changes in IRB. So it's sometimes we forget to factor all of this time. And so now, for example, we still need to get IRB for the implementation of the project. So we might finish training the facilitators, but might need to wait a little bit longer to actually start implementing the program because we still don't have IRB approval.
I was wondering about that. Every change, you've got to go back to amend or a new approval or, ooh, that's commitment. Thank you.
Thank you.
Hi, I'm Jen Obrexer, and I work together at the College of Nursing. So I wanted to ask about your focus on the young adult age group. Are you concerned about individuals aging out of this? I mean, I was thinking especially about your focus group with such a narrow group. Mm-hmm. I thought maybe your presence in the community, some momentum, people come in, but what's your plan for that?
So that also changed throughout the years. So initially our intention was to put together a program that is only for young adults. So for those 18 to 25, even though we do know that programs like this are needed for younger. However, with the feedback we got from the focus groups and also some of the one-on-one interviews is that we need a program that involves multiple generations within the community. So it is not going to be focused anymore on just 18 to 25, but we do want to have half of the participants in this age group and the other half older than 25. The facilitators are going to be 18 to 35 age group. So it's going to be a mix of ages only because, again, the participant talked about how this dialogue and these discussions are needed within the community at all age levels at this point. Before we just focus on the youth themselves. Yes. Yeah.
Thank you. Any other questions in person or via Zoom?
If not, there are 2 questions that were previously submitted. So I don't know if there's any on chat. Are there? Oh. Thank you. Good. All right. Yes, we received questions online, I guess, through the registration. So the first question was, how can social work specifically assist Arab American patients in healthcare settings, given your research? So there's a big role for social workers, obviously, in this line of work. So again, my community partner, Atidal Shalabi, is a social worker. So she has developed this work throughout the many, many years. There's a lot to be done. So even though I'm a nurse, I've done a lot of the work in the community. I definitely appreciate all the disciplines, especially working around health equity and social justice, to come together because we all have different roles in the community. So I've seen a lot of social workers doing amazing work in the community, just listening to patients, listening to your clients, understanding their needs, hearing their experiences, not stereotyping or making assumptions about who they are because of their name or their background or their religion. It's just understanding that this is, I think, one first step, whether you're a social worker or a nurse or a physician. This gets you to really start this trust with the community. And acknowledging that there are power differences between us as providers and healthcare providers and the patients we work with, and how to address that in the clinical setting is important. And then the second question was, what prompted you to start working with the Arab American community? I hope I answered that question in my presentation, but I'm Arab, I'm Lebanese, and so this is work that I see is so much needed within my community. And so this was like the most important reason for me to get started on this work. And so I also want to make sure that other individuals see themselves in the work that I do, and that there's always room and need for representation in this work. So I hope I answered those questions.
Thank you so much. Let's give another round of applause
Thank
to
you.
Dr. Abboud.
And I want to
Thank
thank the
you.
center so much for inviting me. Thank you so much.
Thank you for accepting our invite. So I'll close this out here. I'll move up here. Okay. Thank you again. Miigwech. This is one way to express thank you in Potawatomi. It expresses a desire to reciprocate in the future. Thank you to Dr. Abboud, and thank you to the Odeh Center team of Adriana and Samina, as well as our OVCHA thought partners in all of our work, Michael and Brian. Bama pi mine, or until another time in Potawatomi, as there is no word for farewell, as we expect to see each other again very soon. Thank you all so much for attending. We have a form that we've dropped in for evaluation that we would really love any and all feedback, as we're trying to always make improvements. And we'll also show it so that you folks in person can see it. But thanks so much. And the recording will be online, so look out for that. Thank you.